welcome to faculty and students in HPA and across SPH and other places across the university. We're really delighted to have you here today. And Beth Calhoun, who many on this Zoom meeting will know because she used to be in our very own HPA department. Currently, she's Associate Dean of Population Health at the University of Kansas Medical Center and also a professor there in the Department of Population Health. And she's also served as Associate Vice President and Executive Director for the Center for Population Science and Discovery at University of Arizona Health Sciences, where she went to after she was here at UIC. And while she was here, she held actually a number of hats here. She was director of our Center for Excellence in Eliminating Health Disparities. She co-directed our UIC Center for Population Health. And she was principal investigator on a number of NIH studies and has worked and co-authored with folks here in HPA. And we're really excited to have you back here, Beth, to give a talk. And in fact, actually the opening talk of the series, the first few meetings were with students. So we haven't actually had, those meetings were just organizational meetings. So it's really the first talk of the semester. So your title, Improving Population Health Through Patient Navigation. Welcome, and I'll hand it over to you.
Okay, thank you. Thank you for that warm welcome, and excited to see a lot of faces. Wayne and Sage, hello, of people I know. So I've been doing patient navigation work for, I'd say like 30 years, with the idea of really improving and promoting health equity, the differences in health outcomes that are linked with social, economic, environmental disadvantage, and a lot of it is very costly. But if there's any students on the call, so this is the most recent estimate, which is over $1 trillion. It was published in 2011, and I believe it used $2007. So there is an opportunity to relook at how much this costs, because this is an old estimate. But I'm sure it continues to be very costly. So this is our senior, the first author here is an emeritus, Dr. Warnicki, who is from UIC. And this model was developed through the Centers for Population Health and Health Disparities. So, health disparities have a pretty small sort of biologic or genetic component. There's, individual risk factors, so age, race, acculturation that contribute. There's social factors and things like social support. Can older people who no longer drive, do they have family members who can get them to their preventive screenings or get them to healthcare visits? All impact the ability to be proactive and healthy. There's, social and physical contexts that matter, neighborhood disadvantage. One of the things I'll talk about later was, in Chicago, we looked at the effect of living in a neighborhood that had a FQHC, a neighborhood that didn't have an FQHC, and a neighborhood that was eligible but didn't have the FQHC, and how that impacted on people's health. There's obviously institutional impacts, and finally, public policies. I think at least, some of your professors here do smoking. I think smoking is a very good example of people really didn't quit smoking as much. Well, obviously we knew that it was bad and we told people it was bad, but when you make people smoke outside or you ban smoking from, inside restaurants, and I hope I'm right, Lisa, that I think some of that, impacted and helped promote people's health. So why navigation? Well, the health system is very complicated to navigate. Anybody who's had any major illness will know that. And there's not a lot of support, and the role of navigators has been around, but not everybody gets them to help people. So the goal is to promote health equity, to develop social support services that are cost effective, that help improve efficiency and provide quality outcomes. And really the goal is to increase coordinated care and help people, get a medical home. So navigation really started to be evaluated in 2005. So the then president of the American Cancer Society, Dr. Freeman, had been a surgical oncologist in Harlem. And he became so frustrated with operating on women that were destined to die. So he's like, we need to change this. So he did a pilot with some American Cancer Society funds and hired a woman from the neighborhood to really help women. So his initial vision was, when you have an abnormal diagnosis, we want people to act on that, not get lost to care. So he testified before Congress, and then Congress, and Congress created these programs. So the first one was through the National Cancer Institute. So there was a National Navigation Research Program. The Center for Medicaid and Medicare Services did they looked at sort of the whether this could be done in a cost-efficient manner. And then HRSA actually broadened it to more chronic disease. So it was outside of cancer in the HRSA demonstrations. So we in Chicago were one of the NCI navigation programs. There was 9 sites nationally, and there were 4 screenable cancers: breast, colon, cervical, and everybody had to have a continuous concurrent control group. So the sites were across the country. We had uniform definitions of eligibility and outcomes. And as I mentioned, Dr. Freeman thought the time to intervene was at the abnormal screening test, or if somebody had symptoms. We recruited over 12,000 participants. And like I said, our outcome variable, T1, was the date of the abnormal screen to the date of resolution. So the date of an abnormal clinical breast exam, cervical pap smear, a colonoscopy, to the date that the biopsy or imaging study said cancer, yes, no. So given that each system was a little bit different, we had some different methodologies across the PNRP sites, and we used a prospective meta-analysis, and our outcomes were time to resolution, ratios, and we adjusted covariates. So here was, obviously we had a lot more breast cancer patients and much fewer colorectal and prostate. But at the time, we were one of the most diverse clinical trials that the NCI ever had. So if you can see, we had 29% African-American, 42 Hispanic. For those of you in HPA, 36% were uninsured. So obviously this is pre-ACA. But a very difficult population, the right population that we were targeting. So I'm going to cut to the chase here. So in the initial 90 days, you see sort of some did better and some not. But from 90 days to 1 year, this site, this one that's wrong, they ended up doing their study wrong, so that really should be not even put on that slide. But really what you see here is the ability to get people to resolution in a positive manner. So PNRP was successful in enrolling communities of diverse and vulnerable subjects. There was a consistent finding for benefit of navigation and reducing time to diagnostic resolution. And in my case, so this in Chicago, my findings were we found 25% who would have been lost weren't lost, but across all of the sites, it was between 18 and 25%. So you really, the point here is that navigation benefited those who were most likely not to come back, right? So the ones who came back within those first 90 days were patients who probably had social support and self-efficacy, and were likely to do it without somebody helping them. And navigation helped those who were really going to be lost. And so, prior to, I worked with Access Community Health Network here, and prior to doing the navigation, we looked at their baseline data, and up, close to 50% of people who had had an abnormal pap smear hadn't followed up a year later. So it's really, to Harold's point, there's, it's important to follow up with those folks. It now really has expanded, and there's navigation across the continuum, but being the first, this is where we started. So does everybody, to my point, everybody need navigation, and who benefits? So here's the days between the navigated and the control. So, here's that, 20% lost. Navigation eliminated disparities by income. So you see actually a benefit with the folks who earned less than $10,000 a year. Those who were unemployed. Housing disparities. Helped with people with multiple comorbidities. And with social and other barriers.
Can I jump in and ask a question, Beth?
Yep.
Yeah, I thought the slide on the income was interesting, and I'm thinking how that also would be tied to the status of whether you're insured or not, or whether you're on Medicaid and so
Right.
forth. So I'm just, I'm curious, like the reference category was 50 plus, so you're probably in a job if if that's income, and then less than 10,000, you're probably qualifying for Medicaid. So I'm wondering what the interactions are on how the navigation differentially helped people depending upon what type of healthcare insurance or coverage system they were helping on. Like, is this reflecting, how much of this is reflecting income, and how much of it is an interaction with the type of health type of insurance you have?
That's a really good question, and I don't know that we did that actually. And we had 36% who were uninsured.
I'm wondering if you split out that less than 10,000 by uninsured versus Medicaid, where the navigation is helping. Because if you're not insured, are you even going, like, is navigation, what are you navigating to? Because you'd have to be paying out of pocket. So I'm just curious, like how it might differ, or even between the 10 to 19,000, because they may have you may be able to separate it out there between Medicaid and private insurance. Anyway,
good, really good point, and something we should have done, and I have to look back. So it was interesting. This was a 5-year grant. We actually worked together for 10 years and published, like as a group, lots and lots of papers, because people were really committed. But I might have to go back and look, because now it's been a little while, but that's a really good point, and we should have looked at that. I think interestingly, here's another thing that I don't think we anticipated. There's lots of, the teams had lots of clinicians and not so many policy people. So we had a lot more focus on things like, quality care measures. So it actually improved compliance with hormone therapy.
Beth?
Yeah.
This is Betsy Cliff. Could I ask another sort of basic question? So the patient navigators, are they provider based? And then like what types of resources do patients have, and does it vary across like insurance status that come from payers? Like what are the different, do people have more or less access to people who feel that in general who fill the patient navigator role, or are there, because I know there's some of these, increasingly some of these sort of care management or care coordination type roles. Can you speak to that a little bit?
So the navigators are clinic-based. So that's kind of differentiates them from sort of the community health worker. So I would say the navigators really most often are in a health system. I think it does differentiate between different health systems, right? I mean, in our case, we were at an FQHC, so who cater to the uninsured and Medicaid. The resources that the main role of a navigator is to eliminate barriers, right? So the resources may not come from the health system, they could come from, the consulate of Mexico has been activated at times to give money, foundations, the helping with utility assistance, there's programs out there. So that's what the navigators really do, is they try to figure out what's the problem at preventing you from being able to be compliant with care, right? And so a health system historically has said, go eat healthy food, go exercise, go do this, and then you have to come back and see us, right? So very, the onus of responsibility being on that patient. And so the navigators are really, my personal work has been much more with lay navigators. So the people from the community that speak the language, know how to navigate the resources in the community. I mean, there are lots of nurse navigators in cancer, I will tell you, who help them navigate more clinically. So my initial model for this study, I did have a nurse and a social worker, and it became very apparent that we didn't need the nurse, that we needed a social worker. And the best navigators that I've had are been people that are very resourceful. So like I have a navigator who gets glasses for everybody, because you can get glasses from the Lions Club. So, it's I mean, the health system has some resources too, right? So they can, if they have a bus and they do some transportation, taking people to and from appointments. But it varies. And I think the skill of the navigator is also very important. I think that also is different across people, right?
That's really helpful. I just wanted to, I know it's not exactly related to the slide, but that helps put these findings in context.
Yeah. Well, like here with hormone therapy, helping them make sure they understand their prescription, right? And they can spend a half an hour, whereas a provider can spend, not half an hour, right? And in this case, because the people that benefited most were our Hispanic non-English speaking, because when you're working with a navigator who can speak English, they do much better. So in summary, navigation reduces delays in care, reduction, people never can complete their needed care, and it's most effective where the gaps and needs are greatest. So this data, I'm just gonna skip this. So this data was used to, then when we applied for the UIC Center of Excellence for Population Health and Health Disparities, was we had a few studies, and this was, so we now looked at patient navigation in the medically underserved areas. So the purpose of this was to look at folks in the South Side. And as I mentioned, we had a hospital in a neighborhood with an FQHC. We had a hospital in a neighborhood that had no FQHC, and we did a hospital in a neighborhood that was eligible for a FQHC, but with the idea that because they had no social capital, they couldn't even apply for it, right? So we were looking to try to look at those effects. They actually really didn't play out very well, but we did see, similar to the navigation, the PNRP, the original study, that we saw delays, and it was the same delays to getting diagnostic resolution. So this is just Chicago. So really where you do the best is in your loss to follow-up, but also had shorter days. And in this case, so a BI-RAD 0 means the imaging was not great. So you need to come back, right? And redo it. So that's why the days are quite short, right? But we were able to activate people more quickly. So it was statistically significant. So relative, now here's some insurance, Lisa, because this is mine alone. Relative to women with private insurance, women with Medicaid take longer to achieve diagnostic resolution, and Medicare had no effect. Age was associated with women who are older taking longer, and women who are 30 to 39 taking the shortest. And Blacks were more likely to get early resolution than others. So navigated patients were less likely to be lost to follow-up than controls. Marginally significant, I say. And women on Medicaid had a higher chance of being lost. And age, race, and marital status had no effect. So BI-RADs 4 and 5 mean something is suspicious. And in this case, the mean was shorter in the control group, but the loss to follow-up was improved in the navigated group. So no significant on the time. Women aged 70 and above had a longer time to diagnostic resolution. I would say that's a very good thing, because if you have cancer young, it's much likely to be more aggressive. And married women have shorter resolution times than non-married. Okay, so then some of this data was used by Dr. Molina to get an R21 to look at empowering Latinas to obtain breast cancer screening. And then that led to another R21. So I don't know if Yami's on. Yami, yay.
Hi, boss. Thanks.
Hey, how are you?
Good.
See, you were part of my talk.
Appreciate
All
it.
good, right?
Mm-hmm.
All right, so then I had the pleasure of, so obviously to my point earlier, we're trying to integrate, you start with practice, then you get some science around it, and hopefully you can impact policy. So the goal here was to get the Commission on Cancer to integrate patient navigation into their standards. And they did just that. So the Commission on Cancer, it's 1,500 plus hospitals across the country. When they get accredited, now have a patient navigation standard that requires them to establish a navigation process that identifies resources, and they have to address specific barriers, either by themselves on site or by referral. And as part of this, the Cancer Committee will report back to they have to identify the population that they're going to be served, the health disparity or barriers that they're trying to impact, and a description of the navigation process and the activities that they're doing. I will say I was a member of the standard writing committee. That is about as fun as watching grass grow. We spent days crafting like 10 sentences. So then my navigation journey takes a strange twist. I think somebody in Governor Quinn's office Googled Navigator, and they contacted me and said, hey, do you think you can help us with the rollout of the Affordable Care Act. And I was like, sure. And that we did. So I'll tell you a little bit about that. So where we started was in 2002 was there was over 47 million uninsured, and in Illinois, 1.8. And these were the people that we were trying to enroll. So there were 2,000 and almost 216,000 children, 69% who made less than the 200% of the federal poverty level, 24% of young adults 18 to 25 were uninsured, 21% of working adults were uninsured, 27% Hispanic, 23 African American, and 13% white. And so here was the goal was how, 36% were going to be Medicaid adult eligible with the increase in the federal poverty level, 10% of Medicaid eligible children, and then 21% on the subsidized marketplace. So if you made up to 400% of the federal poverty level, you were eligible to get some financial subsidy for your premium, so paying for your health insurance, and other people were able to get subsidies for their co-insurance, so your deductible or your co-pays. And then so the unsubsidized marketplace would have been people that made over 400%. So 20% of those who were not insured. And then we had about 15% that were ineligible for coverage due to their immigration status. So the interesting thing was, so the ACA did create this workforce of insurance navigators with the task of really providing low and moderate income populations with information appropriate linguistically and culturally about their coverage options. So the UIC team, because I cut some of these slides, we designed and delivered a 3-day curriculum in person and online from 2013 to 2016 to over 1,500 navigators and assisters across Illinois. And then as part of 12 to 16 hours of more, and ultimately more than 4,000 certified application counselors and about 1,500 navigators were trained through the UIC. And why that is because Illinois chose to be a partnership state. So we were both a federal and state marketplace. And so the grant funding for us came both from feds and the state. But Illinois passed a very robust certification bill that required much more than what the federal training did. So as a result, they had to have the in-person training, and they were required to have 12 CE units every year. So the federal training was about 5 to 20 hours, and ours was the 3 days. And they needed background checks, and they were, we saw all of our training verifications through the Department of Insurance. So the Department of Insurance tracked these guys' training. The team was diverse. I'm lucky I found them because they were excellent. They weren't all from UIC. We have a doctoral student who did her dissertation on this. Yeah, it was great. I actually met her when I was at a breakfast at the Blue Cross and Blue Shield. And I was like, oh, but she's like, I want to go to school. I'm like, oh, good, perfect. I've got a perfect project for you. So we used all kinds of multi media approaches and adult learning theories. And I had someone who ran a Medicaid office. So we did, let me see, we did, so here we had like the ACA overview, roles and responsibilities, ethics, culture of coverage, core eligibility, Medicaid, and you know, understanding health insurance is very complicated and very difficult to teach. Then we taught the marketplace and all about the advanced premium tax credits and cost sharing. And then there was about the shops, so the small business, special populations. And I really kind of the thing that I liked most about doing this is through our continuing ed, you know, some of my health stuff was able to come to fruition. You know, we sort of got the perfunctory stuff down, but through continuing ed, you're able to really help people, help the folks that they're working with understand how to use their insurance, how to establish a medical home, how to go and make sure you get, you know, as part of ACA, all your essential health benefits allowed, you know, you to go get a mammogram and it costs you nothing, right? And those, so their screenings are free. And so we were able to do some of that. Like I said, communication and health. We taught them about community outreach. And we were required by the Department of Insurance to make sure everybody passed a test before they were able to get licensed. And we did that. We had a diverse group of navigators in terms of, you know, 20% were Black. I mean, you can see this here. No college. Actually, I guess we have a little heavily more college with lots work experience. And they worked at, a lot worked at healthcare organizations, but a lot also worked at community organizations. Some worked at the government. We had, most people were employed. But 13% were uninsured. So we did a pre-test, post-test. So the pre-test was close to 80% and the post-test was close to 92%. So it was statistically significant. So we felt like we did a good job training people. A lot of people, these are the type of things that they did to outreach. Lots of events, lots of phone calls, lots of educational presentations. Actually, it was interesting. Our most successful place to enroll people was in the library, which is interesting. Now I pay attention every time I see a library. But there wasn't, you know, there's more challenges. That's the thing. Just getting people health insurance isn't going to improve health equity, right? You got to know how to use it. You got to use it. And so the newly insured did better than the full year of insurance. And the good news is, for the first time in 2016, you know, we had our lowest uninsured rate. I haven't would have helped. Can I do that, Lisa? Is there, ask a question of the, does anybody know?
Can faculty answer, like the extend health insurance coverage to young adults through their parents' employer, maybe?
Well, that's one thing.
Medicaid, the individual exchanges, the subsidies.
Yep. Well, so there was a mandate, right? So initially you had a little baby fine the first year if you couldn't show that you had insurance. Bigger, and by the third year, it was like you're getting fined way more than it would have cost you, right? To make, so like a big stick. I mean, it was a graduated stick, but Donald Trump got rid of that mandate. That's the one part of ACA that's been disassembled. So an interesting question for a PhD student would be to look at, the impact of some, do an interrupted time series on, because Marcus, those getting rid of the pre-existing conditions and letting the children, that actually preceded ACA, right? I mean, it kind of got the ball rolling.
So sorry, Lisa just posted that the current uninsurance rate is 9.6. So why do you think it hasn't, since the mandate's been invalidated for quite a while or zeroed out, why do you think it hasn't bounced back up?
Well, that's good news, right? I mean, then I think people are happy to be on it, and I think the folks that the folks that expand, states that expanded Medicaid, obviously those people, what's the reason not to get rid of that? And depending on what marketplace you're in. So Illinois was very competitive, and it's a pretty affordable. I actually just helped a carpenter who's working at my house, and he's 32 and he has no insurance, and we signed him up. Well, Michelle helped me basically sign him up, but it was only $132 and he got vision and dental. And, I think that's good. Most people then are keeping their benefits.
Yeah, and the low rate, just to jump in, wearing my labor economics hat, is that, right, a lot of people have jobs right now. The economy's good. So,
Right.
it may have nothing to do with AC. So I haven't looked at the breakdown, but it just could be because a lot of people have employer-based healthcare right now. So that could be why there's less uninsured, because more people have jobs, and there might have been a change in the composition of those jobs, more of them may be full-time than part-time. I don't know. I'm just speculating.
Yeah, but no, that's a really good point too, because it is. People are employed and the economy's doing well. So, okay. So basically, as a group, 21 million were enrolled. So for 3 years, every state, even if they didn't want it, got federal money. So after I left here and was in Arizona, there was not anywhere near the robustness of what we did in Illinois. And there was hardly any health plans participating, so it was very expensive. So didn't work well for people in Arizona, even though so it did well for the expanded Medicaid, because they did expand Medicaid, but the private sector didn't want to play. I think, the future of navigation, we're going to continue to improve outcome measures. So about 10 years ago, the group with the NCI and the HRSA group and the CMS group, we all got together, and we had 100 organizations, and we published a supplement in cancer to sort of talk about the metrics that we recommend, right? So in order to move a field forward, we want everybody to, if you're going to look at caregiver burden, let's all look at caregiver burden the same way, right? Or if you're going to look at, patient-reported outcomes, let's all look at patient-reported outcomes. So we did a supplement in cancer. We're now doing a new supplement in cancer. So I chair the evidence committee for the American Cancer Society Roundtable on Navigation. And we did a national survey this time to look at navigator programs across the country. And we had about 800 or so organizations respond. The good news is, and actually 10 years ago, we also did a survey. We just published papers on. 10 years ago, 90% of navigator programs were grant funded. 2021, 90% are organizationally funded, which is really, so that's good news. bad news is they are good at collecting patient metrics and outcomes. They're not good at collecting organizational metrics. And so sort of the challenge, right, with a position like a navigator who doesn't get directly reimbursed is that they're a very vulnerable position, especially in places that don't have a lot of value-based care, right, where they have some bundled payments. So only 25% are tracking things that would be, you know, something you would present to a cancer center director, and, you know, to say, here's how I can sustain my program, and here's the benefits that are, you know, to you, and what my navigator did. So being some, you know, because most of the folks who do this are clinicians or nurses or the lay navigators. So we've been, the roundtable is really focused on sort of the economic sustainability, and we're building tools to help people sort of track the cost benefits or the, you know, return on investment that you, when you invest in navigation. And the group is also working on some policy initiatives. So to develop, you know, training. When I was part of the first study in PNRP, I led the training committee. And so all the navigators in our 9 sites all had the same training, right? And so it's really important, I think, for training so that you know what kind of skills the navigators have when they, when you're, you know, engage with them. And we don't, there's a lot of states that are, well, not a lot, there's a handful of states that Medicaid actually reimburses for and that have state-based training. You know, I think we have something for community health workers. So we're working on that, and, you know, there are policy initiatives that really to help reimburse patient navigators, and one is the oncology care model. So the oncology care model pays, you know, you can get a shared savings when you save money for CMS. Okay, see, Lisa, I left time for discussion.
Yeah, perfect timing. We were saying that it would be great if there would be about 15 minutes left, and that's exactly what we have. So thank you so much for this talk, Beth. And I think at this point we'll open it up for questions, and maybe I'll start that off. And just going back to the first part of your talk that had to do with the navigators within the health system and the idea of improving these outcomes. I noticed on one of the meta-analyses, I think it was for the, you know, the cancer outcomes, that you, the I-squared measure that basically tells you sort of how much of the difference in the different findings from the studies are due to heterogeneity in the types of studies that there are, was fairly high. And I can imagine that, yes, that would be the case, because across studies, and you showed that nice picture of the US where there were different sites where, you know, these studies were going on. And so I'm wondering, from a policy point of view, obviously, in order to improve health outcomes, we want to know what features of what the navigators are doing and what features are working best, like what type of navigation is helping. And so I'm wondering if, first of all, if there is any understanding on the degree of that heterogeneity across the studies, like, you know, how different were what the navigators were doing. So you said here in your study, it was in a, you know, federally qualified health center, and there was probably specific ways that the navigators were operating within that system. So I'm wondering if anyone's looked at the differences in the type of navigation work or the structure under which the navigator was working, and if they've been able to pinpoint how any differences in these characteristics may have led to better or worse outcomes, so that from a policy point of view, we can say not only is a navigator helpful, but a navigator is helpful when they undertake these types of activities in their navigation, if that makes sense.
Yeah, I think
Maybe we can stop sharing the screen. Actually, then everyone can see. That might actually, I was just thinking, because I keep looking to my other screen to look at you or see folks.
Okay, you hold on, stop share. Oh, there we go.
There we go. There we go.
That's so much better. So Yami, is she here? Or
Yep.
what would you say to that? Like, what are some of the things you found?
I'm so sorry. I'll be honest. I was checking an email. So I didn't
That's
quite
okay. I can repeat the question.
Can I just
maybe
jump
Sage can
in?
jump in.
Sage?
Yeah, one thing that we found, if you remember a couple of years ago, we looked at the effectiveness of patient navigation by neighborhood type, and we found that the effect of patient navigation actually differed by neighborhood, basically poverty, disadvantage. So in fact, patient navigation was more effective in resource poor communities compared to the neighborhoods relatively well-to-do. So that's one sort of evidence that, patient navigation works better in certain, environment or conditions.
I think we show that they work better with various types of barriers too.
Right.
Right, Yami?
Yeah, thank you. Sorry about the pause.
And Yami did stuff. I mean, talk about the social network.
Sure. So the work Beth and I have been doing has also been just sort of rethinking cost estimation. And so not only may patient navigation work particularly well for some barriers and for some subpopulations, but we're starting to show some ripple effects wherein we actually reach people who are not touched by the navigator, but by the patient themselves, their family and friends, who are increasing their screening potentially because because the navigated patient is reaching out to them. And so we were able to leverage the PNMUA data that had non-navigated and navigated patients and showed that navigated patients are more likely to tell others to get screening and to get care. And then those folks are more likely to get care to some degree with some caveats on there. And so we're working now on understanding and kind of estimating what incremental cost effectiveness ratios look like when we incorporate those spillover effects versus when we just consider and bound everything in terms of the patient who received the services, which is good. And then I just want to note also, I think some of this is really timely. I think a lot of what Beth has been doing, for example, in the larger patient navigation network, they contributed to major policy changes or major changes in general. For example, the Illinois Breast and Cervical Cancer Program, they now offer clinical navigations for underinsured patients. And I would say that the evidence around the fact that underinsured patients are particularly vulnerable in the era of ACA and the work that Beth done has really contributed sort of to these changes right at a state level in terms of now offering clinical navigation to people with Medicaid, not just people who are uninsured or uninsurable. So hopefully all that was useful.
I mean, there's pretty overwhelming evidence that it's effective in all kinds of organizations, right? I don't know that there's a lot of nuance there, but I think you do show in some of the more intractable type barriers that it work. It helps those people the most, right? Sage, I think, remember, the social barriers and some of the things that are often difficult to resolve, navigation really is able to.
Right. So I have a question. Maybe Beth and other people could actually chime in. So my understanding is that patient navigators are hired by hospitals or other healthcare organizations, right?
Yeah.
So they have their own sort of areas of service. But when I think about policy, just stepping back and thinking about how we can actually plan in where to deploy patient navigators, I'm thinking more of sort of using big data, to know where the needs are, and then sort of, staff, patient navigators accordingly. So thinking about like MCO models, like step outside of like individual agency or hospital clinics, can we actually think about this as a sort of spatial level, sort of like MCO model, right? So where are the needs, high needs areas, and can we assign more patient navigators based on those spatial level assessment of need?
Obviously that would be ideal, right? To be able to look at, where are people's life expectancy declining, right? Or, where are those areas? I know rural America, life expectancy is going down, and those are often under-resourced, communities that don't necessarily have a hospital or, have the advantage of having easy access to care and having something like a navigator. So in Kansas, there is a ACO that basically had their biggest intervention is having nurse navigators, right, to get people connected and help be able to triage clinical questions and things like that. I think we're seeing more of that, but there is no there was something in one of the Biden's budgets that really was trying to activate sort of navigation and sort of care support, but it didn't make it through. So it's unfortunate, but I'm a cancer person, so for looking at registry data, right, you could clearly look at where are we seeing increasing incidence of cancer, and so using big data makes sense to just deploy a scarce resource.
I see that. Oh, did you want to respond directly to that, Yami, or and then next we'll go to Jerry has a question. His hand is up.
Yeah, I just wanted to note to Sage's point. I know, again, just using our local pieces, the Illinois Breast and Cervical Cancer Program specifically asks lead agencies, so those are the community organizations, the FQHCs, and the health departments, how they're using cancer registry data to guide the deployment of community navigators, community health workers in there. So just to throw out there that
awesome.
authority actually doing this.
I haven't been a little out of the loop there.
Thank you.
Jerry.
Yeah, good afternoon, and thank you, Lisa, for including Beth on today's seminar. I wanted to bring up a slightly different but related topic to what Sage was getting at, is to understand this at a broader level. And maybe there's an opportunity here where, to offer the state of Illinois, some thought leadership about how to do this, because this is not only an academic question, but it's a real policy issue. There's millions of dollars, or billions at stake. As you know, Beth, the state of Illinois passed the Healthcare Transformation Collaborative, which is $150 million a year to do demonstration projects, to do essentially hospital community collaborations to transform how we deliver care. And it seems like there's being a bet now placed that we need to solve this. So do you want to speak to perhaps how we could, position UIC, HPA, others in a thought leadership position, and how do we, do some meta analyses around funded transformation collaboratives, or anything you want to think about? What's the future like, so we can answer these questions?
Yeah, and obviously we have some core strength and expertise at UIC. One of the things would be to look at the Medicaid spending, right, and looking at sort of the chronic, in screenable diseases and things like that, where are expenditures rising, when are things like that. We would, obviously there's through the Illinois Breast and Cervical Cancer Program, there's natural connections to those organizations, right? I would think the state would want to be broader than cancer, though. But maybe there, probably, Jerry, what with, asthma and COPD, I'm sure there's a network, right? And I'm sure there's a heart network, and partnering with those folks to figure out how to deploy and figure out what kind of activities they're doing. Half the battle, I think, is really harnessing the knowledge of what's going on and figuring out how to make it all work symbiotically, right? Others,
I think, maybe just one other comment just along these lines is that, COVID and post-COVID, this whole long COVID issue, there's major concerns about how to make sure that, given that long COVID is a multi-system problem, the heart, the brain, the kidney, the mental health, that's a new disability that's being created at, just before our eyes. So maybe to work with the state on saying, look, there's an iceberg that we're going to run into here. Maybe this is an opportunity to be thoughtful about how we deploy resources to understand how best to address that. So this may be an opportunity for us,
Yeah, no, and you bring up disability, which is a good also thing to look at, right? I mean, I think I just saw something, like 1 in 5 people have some sort of disability. So those are obviously the very, the more costly individuals. And you're right, with COVID, we don't even know what's coming, right? That
I see another hand up. So maybe this will be the last question as we're just coming to the top of the hour here.
Is that me?
Yes, it is.
Okay, so thank you so much for this really informative presentation. My research mostly focused on families of children with autism, and it's different from cancer navigation, but these families also requires a lot of navigation and coordination of care, but they are not really qualified or connected with a lot of medical homes. So there's a huge lack of navigation across the nation. And New York and California has their own system of care coordination for developmental disabilities. But I was just curious if you have any work related to developmental disability care coordination or navigation.
I myself have not done much, but I mean, maybe we could look to New York and California, and to Jerry's point, look and see how more comprehensively to have a state system of, sort of navigation.
Thank you. So I am actually I have to join an advisory board meeting for our PRC right now, which is starting at 1. So I would on behalf of all of HPA, Beth, I would really like to thank you for your wonderful presentation. You actually covered so much in that 45 minutes, so many different studies that you've done over an incredible career on various aspects of navigation. And I think, as Jerry and others have pointed out, just, there's much to come, much to understand even on how we're going to be delivering navigation going forward in a time where we have things like these pandemics going on, where it's increasingly important to figure out how to get people to the types of care and services and multidimensional types of services that they need, whether it be directly, in the hospital or in the community, right? Other types of support systems. So thank you so much. You've given us a lot to think about. And I know you have a busy day too, with many more meetings coming up. So
it was so nice to see a lot of familiar faces.
Okay, keep well, everybody. Thank you.
Thank you so much for coming, everybody. All right, see you soon.
Thanks all.